Good morning. I thank the organizers for giving me this opportunity, and it's funny to talk about physiology just after Dr. Johnson, but still I'll try. Yes, first I'll start with the case. It's a robustness of physiology in stable coronary artery disease. A 53-year-old man. He presented with he had a primary angioplasty in Singapore, and he was advised an angioplasty to LAD and RCA. And this is the angiogram, which showed a FFR of 0.78 in LAD, and a FFR of RCA was 0.92. So RCA was left alone, and he had an angioplasty to LAD with a stent. And he was readmitted with non-STEMI after 7 years. He had not come for review for 7 years. And this is the angiogram, which showed tight stenosis in LAD, which is the reason for the non-STEMI, while the RCA remained the same. Now, he was treated with another stent, and he has been doing well for the last 2 years. So this shows the utility of FFR. The deferred lesion remained the same. There was progression of disease with stenosis proximal to the stent, and that's what we see in DEFA in the 5-year and in the 15-year follow-up as well. So FFR versus medical therapy in stable coronary artery disease is a FAME2 trial, which showed a significant reduction in the primary endpoint at 5 years as well as 3 years, and it's predominantly driven by a difference in the urgent revascularization, but not because of a difference in death or MI. And it is seen at 5 years as well, again because of difference in revascularization. Now, this is the meta-analysis of individual patient data from 3 trials in stable coronary artery disease. There's a FAME2, DYNAMI-3 Primality, and Compare Acute, which showed the stabilized lesions. And they found that in this meta-analysis, the FFR-guided angioplasty resulted in a reduction in the composite of death and MI as compared to medical therapy. And this was due to a reduction in MI. And what is the difference from the individual trials? In the meta-analysis, in the individual trials that less than 1,000 patients and follow-up of 1 to 2 years, while the meta-analysis had more than 2,400 patients followed up for 3 years, and it was drug-eluting stent than bare stent. So this was the difference in the meta-analysis as compared to the individual trials. So why is the topic stable angina pectoris? Why is FFR and ACS different from stable angina pectoris? So this is the data, the revascularization deferral of non-culprit lesions on the basis of FFR, a 1-year outcome of more than 8,000 patients. And here we are looking at the deferred group versus the treated group. Yeah, we're looking at the ACS deferred, this is the ACS treated, and the stable angina pectoris treated with deferred. And you find that in the deferred group in patients who presented with ACS, there was a significant increase in the MACE, while the treated one remained the same. So the revascularization deferral in ACS was associated with the higher 1-year MACE as compared to stable angina pectoris, and the difference was seen within 1 year. Difference was due to a higher unplanned revascularization, while the 1-year outcome in the patients who were treated as opposed to deferred was not different, whether they presented with ACS or stable angina pectoris. So the possible hypothesis was it could be an intrinsically higher risk of events in ACS, or that you are missing the vulnerable plaque in ACS, the triple L, which is the large plaque burden. It may be lipid-rich or a small lumen, which is missed on physiology. Or it could be a misdiagnosis of an ACS culprit lesion in unstable angina or non-STEMI, the FFR or the true culprit lesion being deferred based on negative FFR. And of course, we know about the sympathetic tone, which is higher in ACS. So this is the possible hypothesis, and what does the data show? FFR and ACS is suspect. You have a complete trial where you had a significant reduction in MACE, and here the treatment was based on angiography. We had talks yesterday by Dr. Johnson regarding the flower MI. The FFR was no better than angiography for complete revascularization in STEMI, and the future trial, the FFR-guided treatment in complex multivessel disease associated with a doubling in the risk of death at 1 year, and there was no beneficial impact on other outcome. But here again, 50% of the patients present with ACS. Now, what is different in stable CAD as compared to ACS? In stable CAD, we all talk about severity of ischemia and outcome, but actually the severity of ischemia has no relationship with the primary endpoint, whether it's cardiovascular death, MI, hospitalization, unstable angina, or resuscitated cardiac arrest in the ischemia trial. So ischemia had no relation to the outcome in the ischemia trial, and the outcome was essentially dependent on the severity of coronary artery disease. The CAD severity was highly significant predictor of all-cause mortality, MI, and a 5-point composite endpoint. So what is the pathophysiological consideration? You have a disconnect between ischemia and severity of coronary artery disease, and this underscores the fundamental vascular biology of atherosclerosis. The vast majority of severe flow-limiting plaques remain quiescent and do not cause cardiovascular events, and the risk conferred by the most severe and extensive CAD simply reflects the greater atherosclerotic burden. So it's the severity of coronary artery disease than the ischemia per se, which causes more events. Within each plaque, there may be heterogeneous areas which are at risk to destabilize. Now, what are the clinical implications of this? Among stable CAD patients, CT angio may be superior to stress testing for risk prediction, or a CT coronary angiogram may be a more efficient method for ischemia testing for risk stratification. So you look at the anatomy rather than ischemia testing, and this already come in the NICE guidelines. So the ischemia severity, or FFR, which we do, may not identify the patient with stable ischemic heart disease who benefit from invasive management over 4 years. This could possibly be the reason why we have these results in stable coronary artery disease. So what does the data show, the trials show? First, the RIPCORD 2 is a randomized comparison to assess the value of systematic FFR at the stage of diagnostic angiogram. More than 1,100 patients, chronic stable angina or non-STEMI from 17 UK hospital, FFR at the time of angiogram. And the co-primary endpoint was the cost at 1 year or the quality of life, and the secondary endpoints were death, MI, stroke, MACE, or unplanned revascularization. The co-primary endpoint, there's no difference at the total hospital cost or whether it's a quality of life. And importantly, the secondary clinical endpoints were the same, whether it's angio alone or angio plus FFR. So the summary and conclusions of RIPCORD 2 was a routine systematic FFR assessment at the time of diagnostic angiography is cost neutral and is not associated with significant difference in quality of life or angina at 1 year. It did not reflect the clinical event rate or overall management plan, whether it's OMT, PCI, or CABG. And this strategy, that's a systematic FFR, has no advantage over angiography alone. So FFR is of most clinical value when targeted to a specific patient group. This was the conclusion from RIPCORD. The specific patient group may be a multivessel disease being considered for angioplasty rather than routinely at the time of angiogram. So FFR routinely is of no use. Probably it's of benefit in specific subgroups like multivessel disease being considered for angioplasty. And then came FAME3. FAME3 was the basic hypothesis of FAME3 was you have found that syntax, freedom, best. All these trials have shown the benefit of CABG versus angioplasty in multivessel disease. And FFR-guided angioplasty was better than angiography or medical therapy alone in multivessel disease, and this was seen in FAME and FAME2. How was FAME3 different? It was different in using FFR guidance for angioplasty and second-generation tests, and this was tested against CABG. The hypothesis was that FFR guidance would result in more judicious stenting. Only the functionally significant lesions with need to adverse events would be stented, and the non-flow limiting lesions, which are best treated with medical therapy, would be avoided. And there's a FAME3, 1,500 patients, CABG versus angioplasty, and it is found that there's not inferior, or as Dr. Johnson was saying yesterday, it may be inferior to CABG with higher MACE and PACE with angioplasty at 1 year. So what could be the explanation? FAME3 had more disease severity, the FFR more than 0.8, or the non-significant lesions were only 24% of lesions in FAME3, while FAME had more than 37% of patients, or 37% of lesions. And benefit of FFR guidance is primarily related to avoidance of unnecessary stents and the inherent complications. In cases where deferral rates are higher, you have better outcome with FFR-guided PCI. And when CAD severity is more, and CAD severity rather than ischemia is more important in stable CAD, and FFR measures ischemia. So the conclusion is physiology assessment mandatory. It's essential to prevent unnecessary stents, and the benefit of physiology in chronic stable angina is more for deferral of lesions than for justifying angioplasty. Thank you.